Very good. So now that the recording is going, we can start officially. Welcome, everybody. So glad to see all of you here. Thank you, especially to those folks who have put their cameras on. It's always nice to be presenting in a community where we can see each other. Of course, you're not obligated to turn on your camera if you're not comfortable doing so, but it's always refreshing as a presenter and as a community that we can connect and see one another's faces. So here we are for the April 2025 CodeX Community of Practice. We're excited to be hearing from Dr. Amye Tevaarwerk of the Mayo Clinic. And I'm just going to spend a couple minutes talking about CodeX for a moment before we introduce Amye and then pass it over to her. So for those folks who may not be familiar, CodeX is one of HL7's fire accelerators. There are 8 fire accelerators, and we are a member-driven community. We accelerate interoperable data modeling and implementation, and we focus specifically around fire standard, which is a health data standard produced by HL7. We also are tasked with promoting and seeing the use of mCODE move through the world. mCODE is the minimum common oncology data elements, which are used to help facilitate the transmission of data around oncology care, both for clinical and research purposes. And we believe that and we've seen evidence that the implementation of these standards actually improves healthcare delivery and also research. We're going to hear a bunch about that from Amye. Since then, since HL7 CodeX started in the oncology space, we've expanded into the cardiovascular domain, also into genomics. And so we continue to grow as a community, we continue to grow in our scope, and we continue to see evidence of real-world impact. We're very proud of that. Moving back to 2019, mCODE was first published as a collaboration between MITRE and ASCO and other partners. And shortly thereafter, the CodeX community was born, partly to help promote and broaden the adoption of mCODE. And so we work together on identifying real-world use cases, which is to say problem sets that matter for the world, and then applying open health standards as solutions to some of those problems. We're excited to know that Mayo Clinic has implemented mCODE, and today Amye will be sharing some insights on that experience and the sort of impact that it's been having. Of course, here at CodeX, we're a member-driven organization. We only exist, when our members are engaged and participating and doing stuff together. And so if you're interested in learning more about CodeX, please reach out to me after the meeting. You can also message me here in the Zoom chat. And I can have a more focused discussion with you and your colleagues about what it would mean to become a member of CodeX and how you would benefit and how you would contribute to the important work that we do together. And with that, I have the distinct pleasure of introducing our esteemed speaker, Dr. Amye Tevaarwerk, who is a breast cancer specialist and a professor of oncology at the Mayo Clinic, where she serves as practice chair for the Division of Medical Oncology. Formerly at the University of Wisconsin, she is board certified in clinical informatics and is an EPIC certified physician builder, which I presume means that she builds physicians, which I think is exciting. A national leader in cancer survivorship and oncology informatics, she contributes to NCCN and to the EPIC advisory groups and researches how technology can improve cancer care coordination and patient outcomes. So I think all those things are super interesting. I also think that what she has assembled here for a presentation will be interesting to you as an audience. And I hope that you will collect questions. By all means, put your questions into the Zoom chat or Zoom Q&A, and I'll feed those questions to Amye at the appropriate time. There will also be a call for questions later on in the meeting. Please note that this meeting is being recorded, so if you think of colleagues that would benefit from hearing it, there will be a hyperlink shared in the meeting notes after the meeting has concluded. And with that, I will pass the proverbial conch over to Amye, and I think Amye is going to present her own slides, so I will stop sharing, and Amye will do so.
Let's make sure that we successfully complete that transition. We're still on the objective. So, yep, perfect.
Yep. You're good to go.
I will confess to everyone that as along with most Zoom presenters, right, I find it difficult to monitor the chat and do the talking. So, you know, there is
I've got you covered.
What, you got me covered? All right.
Got you covered.
So, hopefully what we're going to try and do today is walk through some of the challenges that I see with our current oncology data paradigm. Describe how using or collecting structured data or discrete data, whatever term you really resonate with, within the EHR or whatever your care delivery tool is, can transform the data paradigm. And then describe how, at least in the case of Mayo Clinic, we're beginning to use that structured data within the context of our EHR to drive both research and practice. And we may be able to get a little bit into sort of things beyond that. So let's chat just a little bit about the old versus what I would call the new or newer data paradigm. And this kind of reflects back on what a lot of us would think of as a system problem within the US healthcare system, which is that we have lived through a digitalization of paper. So historically, if I think back to when I started medical school and even residency, which is just dating myself, right? But that's what it is. Our clinical records were paper-based. So I trained on paper charts, I wrote paper notes. And as our medical systems, as our healthcare systems adapted to sort of electronic health records, we essentially lived through a process where we digitalized our paper, where we took what we were comfortable and used to doing on paper and just made it electronic. And one of the consequences of that is that important data about the cancer story is often present as free text within the note or a radiology or a pathology report, as is exemplified here. And I apologize if any of you were able to read the really tiny type in the note. It was so hard for me to find an example of an old paper chart note that this is really not an oncology note, it's a critical care medicine note, but whatever, it illustrates the point, right? So here we basically have an example of a paper note, and then you're essentially just taking that process where instead of writing it by hand, I'm typing or dictating it, and just sort of recapitulating that very free form process, which is super customizable, but then leads to consequences of everybody can do it differently, and you can't necessarily rapidly extract this information out without an additional curation process. And what that does is it sort of contributes to what I refer to as either the swivel chair or the human Band-Aid approach for curation of a cancer journey or the cancer story for a population of patients. So when someone is reviewing a chart for clinical purposes, they're relying on this free text information in the notes, and they're essentially reviewing it and creating the cancer story and journey in their mind, right? That's fine. We can do that well as clinicians. But then for administrative or research purposes, we have to do an additional manual curation, and we extract all this precious cancer information to external databases. And examples of that are the Cancer Registry or the RAVE EDC, right? We're all familiar with this. And basically, when you're thinking about that administrative or research purpose, you have a human Band-Aid, in other words, a person, whether it's a CRC or a cancer registrar, swivel chairing, where they transfer data between two electronic systems, the electronic health record and then whatever electronic database they're working in. And when you think about it and sort of really appreciate that, and I think it took me many years to sort of see this for the really painful process that it is, because it's just kind of an accepted phenomenon in some ways, it's just absolutely ridiculous that we would rely on a human to transfer electronic information between two electronic systems, right? Humans are a precious resource in medicine. And honestly, not only are they precious, we're not very good at transferring data in the way that a machine might be able to do it. So the consequences of that manual curation or that human Band-Aid approach is that we're really limited in who we capture information on. We have to be very deliberate. We're limited in how much information we can capture due to cost and time. We're limited in how fast we capture that information. So if you think about cancer registrars, right, they are deliberately not touching a patient chart until 6 months after diagnosis, not because there aren't important things happening, but because they really want to kind of try and touch the chart once and then be able to get almost all the information out. And the best way to do that is to just start after most things have happened. There's a limit in our accuracy. Partly because every time we transfer data using humans, we have to have sort of additional QA processes. And then ultimately, there's also a really important consequence of we're then limited because we've transferred and structured the data in other places besides our care delivery tool. We're limited in our ability to use that data that's been preciously curated in these other ways in the place where we're delivering care, namely the EHR, to support us in placing the necessary orders, to support us in placing the necessary steps, because it all exists as free text and it can't be used to drive or trigger EHR processes. So that system process could also be referred as to a lack of structured EHR data. And it is absolutely possible, as hopefully everybody on this call knows, to enter data into the EHR as structured or discrete or digitalized data at the point of care. Now, in order to do this, ideally you'd be using a defined language, right, linked to a coding system. Again, mCODE, as Brian was sort of describing at the start of this, is such a language, right, where you sort of define, these are the important things that I minimally would like to define or capture about my patient with cancer and their cancer journey, and use agreed upon answer choices so that I could share my information with other systems and we could compile our results to develop an even larger patient population across multiple healthcare systems. You could make other choices, but this is the one that we're sort of talking about today. Once that data is digitalized, it can be used or pulled from your EHR to other places, research databases, Tableau, Power BI, whatever you want. It could be pulled to a cancer registry, and you could use it both within your system as well as across them. And the structured EHR data is in many ways an excellent source of real world data and real world evidence for persons with cancer, right? It can be extracted rapidly. If it's entered at the point of care, at the time that the care is delivered, it's as close to real-time data as anything else we can do. Once it's present in an EHR as structured data, it can be extracted with minimal effort. And I'm going to put minimal in quote marks, at least because you'll hear that there's some additional effort that it then takes to use it. Like you have to have a plan and you have to have some IT knowledge. And probably really importantly is that it's actually very representative of the broader population of patients we treat. If we're thinking about a lot of the evidence that we use for making decisions, it's based on a highly selected population that may not match the general population, either in terms of health or age or ethnicity, et cetera, right? So this is in some ways the best source of data that we could ask for. But how do we get from our digitalized free text to structured data? And so I'm sort of showing you some screenshots of a real world example where, you know, we are now presenting that information in a digitalized format. And this example is actually a real one where we attempted to digitalize this particular case. And you can see sort of that it's following a different flow. It's still there. You could argue about whether it's as readable. Speaking as a physician, I would say the most readable data is the one you're used to looking at. But this is actually a structured, digitalized version of that free text example. And again, as we've sort of described, the data language or structure that we're interested in using and have been focusing on here at Mayo now is mCODE, or Minimal Common Oncology Data Elements, which is shown here in STU 4. You can find some additional information about it. This is sort of a data language that has growing momentum. As I mentioned, there are other examples of data languages, but you know, if you're going to be doing this work, you kind of have to choose one. You can argue back and forth about merits of one versus the other. I think this one's nice and simple. And we've been using it for a while, and it has some growing adoption within the EHR vendor community, including Epic, which of course is a fairly major EHR vendor for most of the US academic sites. So, all right. Well, let's talk a little bit about our experience here at Mayo Clinic and starting to make this transformation from free text to structured data within the cancer span. So I would encourage you guys to sort of look at our pilot experience where we talk about some of the specific decisions we made and why. As we move forward with our pilot and trying to undertake this journey, and this started for us back in 2022, as I moved from the UW to Mayo, we focused on note-based tools. And the reason for focusing on our note-based tools is that we were most interested in capturing 5 data categories. So stage, disease status, performance status, the intent of treatment, and the intent to change therapy. Those last 4 especially can change from encounter to encounter for a patient with cancer. And therefore, they are most frequently located or found or curated by other people from clinician notes, specifically providers such as a physician or an NPPA. So if you want your physicians and NPPAs to contribute to data, you are most likely to get them to do that if you place the data creation in line with notes, which is a process that they are used to and have to do all the time. So Figure A shows the 5 data categories as well as the answer choices that we were going after. I will note that they are actually slightly different if you pay careful attention from what's actually offered in mCODE, because we had to include a couple of extra options. We then, and this is where the physician builder part comes in. So I don't build physicians, I build in the EHR, Brian. We used functionality for stage that was pre-built by Epic. So this is largely within the context of Epic as an EHR vendor. And then we built additional smart lists, which were capable of capturing structured data. So this is incredibly simple EHR build. This took about 10 hours of time, tops. And it turned it into a system smart phrase that could be incorporated into the provider note templates. It's incredibly flexible in that they can break it up. They can locate it in different places. We haven't attempted to standardize that. But as they move through creating their notes, it generates this text that then can be extracted the moment the note is signed. And since notes are typically signed within about 24 hours here at Mayo, this data is as close to real time as you could really hope. During the course of our pilot, we were able to very successfully demonstrate for only the 14 providers that were involved, a significant improvement in staging, as well as finally being able to extract those other data categories from the system. It's not that they weren't present before, it's just that we could not extract them without curation. We carefully tracked time in the chart. There was no increase. Our cancer registrars assessed the data, and it was generally highly accurate. The part where this can sort of be a little questionable is if you stage it and then more information comes in, there's a process of having to catch up. So depending on where you cross-section it, it can appear like it's not yet accurate. But that generally improves at the next encounter. It's very sustainable, as you will see as I move through this. So all of the pilot individuals have sustained their behavior now since 2022. And one thing I'll point out is just 6 months of data capture by 14 providers led to 5,000 encounters worth of data. So this generates reams of information very rapidly. Among the things we learned from the pilot is that there's actually quite a bit of provider variability. That's probably not a surprise to folks who work with physicians and NPPAs. We like to be independent. We like to do things a little bit differently. And that can mean that sometimes we need support in different ways. So some folks, as you can see in the top sort of B, are very successful with just sort of this voluntary, put it in your template, plug along. Others struggle a bit more or have a very sort of broad sort of uptake in terms of sometimes they seem to be doing well, sometimes not as well. And also we found that staging lagged behind the other data elements because staging required them to leave their note and go to another place in the note to complete it. Even though it only had to be once, it's that step of sort of leaving your note context and coming back that could lead to some additional problems. So as we expanded past our pilot, and this somewhat complicated figure is my attempt to visually describe to you, we did a pilot in 2022 into 2023. We figured out kind of what worked well and where we might have to offer some additional support. In 2023 into 2024, we essentially had a voluntary extension of what we were doing. We expanded across all the breast medical oncologists in our enterprise from summer of 2023 into the fall of 2024. And then towards the end of the summer of 2024, we expanded to our GI medical oncologists. That was all initially voluntary, and we didn't have a lot of additional support. We were just using the techniques that we learned in our pilot. In 2024, fall of 2024, we included a number of additional supportive interventions that I'm going to describe to you. And then the description that I'm going to give of the phase 2, which included this additional support, we had about 45 providers. We have now done 6 months pre and post data capture. I'm going to point out to you the vast number of visits that then encapsulates, right? Because we have a larger group going for about 12 months. So again, that like oodles of data that is being generated, rapidly starts to grow. I will note that this does include some of the additional pilot providers who onboarded in 2022. So the support options that we included, and there were a variety of them. So the first thing we did is a closed visit validation. So many folks who use Epic or an EHR will be aware that if you're a physician and you attempt to close your note and you haven't entered a level of service, or you attempt to close your visit, your encounter, and you haven't entered a level of service or put in a note, the system won't let you complete closing the encounter. And the reason that's the case is, your healthcare system doesn't want to miss a billing opportunity, and they don't want you to not put in a note that supports that billing. Well, you can repurpose that. And if you look at some of the examples that exist for driving this kind of work that are there across the system, this is actually a very common approach for driving structured data capture, is to sort of put something supportive there. It's not terribly interruptive in that it's only happening as you close your encounter. And this one's a soft stop. So in other words, it's a reminder, but it's not forcing you to do anything. And it says, hey, you're about to close this. You got a malignant diagnosis on the problem list and you selected it as a visit diagnosis and it's not staged. Maybe you should stage it. We also engaged with allied health staff to sort of who screened our charts in advance, looking for clinical trial matches to have them enter the staging and route it to the provider who was going to do the visit. And there's an example of that here under routing, where we're sort of using pre-built Epic functionality to route the stage. So again, this did not require build. This was taking advantage of existing Epic functionality. The closed visit validation does, of course, require build, but it was relatively simple. And then I want to emphasize sort of the third intervention, which is education. And when I say that, I don't mean it lightly. This is education to the tumor group and the faculty repeatedly, right? Over and over and over again, to tell them why we were doing that and then to show them how we were using the information. There was a little bit of individual nudging to providers who seemed to have a little bit more trouble sort of uptaking this and putting it in their templates. And here you see the results. So the impact of those interventions, comparing the 6 months pre-closed visit validation. So we use the closed visit validation as like the most defined. We could tell exactly when we went live to the day, right, for each of the providers. And you can see here that what that does is it basically takes all the low end sort of having trouble contributing to this data capture providers, shown here in green, and moves them significantly up. The ones in yellow who are already doing pretty well, most of the individuals who are there in yellow, in the yellow arrows, we're already at about 80% or better data capture. They stay where they are. Initially, we thought we were seeing a slight decrease in that group, but it turns out that as you follow them over time, they basically, whatever was going on was probably, they were having a bad month in clinic or they were on service or something. So it substantially pulls the whole group to the point where you're seeing a very significant improvement in the ability to capture data. So we're now over 80%, and we have a much sort of tighter distribution of the ability to participate in the structured data capture. All right, so you might say that's interesting, but it's a little bit like talking about stage without talking about what stage is used for. Well, we have a lot of use cases, and I'm going to emphasize that the use cases are probably constrained by our ability to build. Right, so my colleagues can drum up or think of use cases faster than we can build them. So here's sort of the first use case that we used, which was to just try and take a look at our population in real time in some sort of aggregate. So we had some pre-built data dashboards where we started pulling all of this mCODE and staging information, as well as other details that we care about, to just summarize what the populations look like. And this is extremely useful when we think about opening clinical trials, right? So if I wanted to know what % of our population in real time gets neoadjuvant chemotherapy, I can tell you it's about 20%. If I needed to know what the actual ER, PR, HER2 distribution was, I could actually drill down to that. I could tell you what stage 1 or stage 2. I can tell you what the intent of therapy is. And then I'd like to highlight intent to change therapy. So one of the reasons we focus on that is the first sign that a patient might be eligible for a clinical trial is when we think about changing a therapy. That's usually where most clinical trials are kind of looking for their study participants, is as you change treatment. And so that's been critical for us in thinking about what was our even likely denominator for a clinical trial. So this just data sets that are large, pretty complete, more than 80% complete, and real time, not delayed like a cancer registry, has been really impressive and important for us here in Rochester in medical oncology as we start to think about our breast and GI trials. So as I said, it drives research because it lets us understand our population, but we've also built research reports. So we can now, using this, take the high-level trial eligibility criteria, which are often linked to things like T, N, M, ER, PR, HER2 status, look for the patients who have upcoming visits, and start to push messages to treating providers and patients with a notification that the patient's potentially eligible. So one of the issues with doing trial matching, of course, right, is you have to make sure that someone knows the patient is eligible and get that information to the provider and the patient as rapidly as you can so that you're not causing delays. And using our research reports, we can track the outreach and the outcome. I don't have the ability yet to show you kind of the results of that because we've really sort of started just engaging in that, but we do sort of, at least anecdotally, think it's been very sort of useful for us. Our research reports, they're a sort of a use of a healthy planet functionality, which again is existing Epic functionality. It lets us reach out to the patient, it lets us track that outreach, and it also lets us message the care team. We've also been using this data to build what we call our practice advisories. It used to be known as a best practice advisory, or BPA, can't say that anymore according to the FDA, to sort of potentially identify patients who are eligible for a trial. And again, it's relying on those sort of high-level criteria, attempting to kind of close down your denominator and not have to screen all the patients who are coming into clinic. So this is an example of a trial being conducted by my colleague, Dr. Cathcart-Rake, looking at a drug that potentially decreases neuropathy. That trial needs patients who are breast cancer patients who are M1. So again, those are structured data elements. You use a ICD-10 or code, and we use our M1 fields from staging. And then you need to know that they're starting Taxol or Taxol plus Herceptin and Perjeta. Well, it turns out medications are structured in beacon treatment plans, and we can take those 3 elements, and the minute those 3 criteria are satisfied, the research OPA basically fires off a message into an in-basket pool to a coordinator saying, hey, someone just placed this Taxol plan. Let's see if we can work with the provider and the patient to see if they are eligible for this trial. So it's not perfect in that there's some additional criteria, but at least it lets you close down the denominator. You don't waste a lot of coordinator time just screening chart lists or clinic visit lists. And that takes advantage of the mandatory gap while we wait for prior authorization, right? So it's been really important for us in that way. And again, we're sort of tracking what the impact of this is going to have. I will say in future state, these OPAs, we can't continue to build them one-off. We are looking at ways to do this more effectively because this tends to bottleneck through our analysts, and how fast we can turn one on basically depends on how fast they can build it with me. This is another example of a patient care, so our standard of care OPA or practice advisory. So many of you on the call will know that the FDA approved ribociclib in the fall of 2024 for node negative breast cancer patients who had sufficient risk. The criteria for who has sufficient risk are a little complicated to remember. Basically, your patient has to be T3, ERPR positive, or they have to be T2, grade 2, but if they're grade 2, they have to have a high-risk oncotype or MammaPrint or a Ki-67. And so it's really kind of a little bit of work on the part of a clinician seeing a patient in a busy clinic to kind of remember this practice change. So we built an OPA. It took us about 2+ months from when the FDA approved to turn it live in the system. And then most importantly, from the perspective of someone like myself, who as a practice chair has to pay a lot of attention to quality metrics, it also helps us figure out why a patient's not on a CDK4/6 inhibitor, such as ribociclib. So you can always tell when you do data polls of a chart, which patients are on endocrine therapy and something like ribociclib, but what you can't tell in the patient population who doesn't have that ribociclib is why. There are many good reasons why a patient might not be on it. For instance, the patient might not want to do it. The patient might have contraindications, but it might also be that you forgot, and that would usually take a manual chart curation. Well, with something like this OPA, you can get really good insight into the missing data, what's been previously missing of why the patient's not on it. And here I'm showing you an early screenshot, but I would tell you it's been working well, and I just haven't updated this slide. If we sort of think a little bit about how could you do something or leverage this kind of information beyond Mayo, right? So when I talk about this, a lot of folks will say things like, well, that's great that Mayo's doing it, but, you know, that's fine, that's Mayo. Well, there are lots of places that you can sort of potentially extend this work beyond to other institutions. So we have a project that's ongoing through the Alliance where we're actually looking at, could we use this sort of real-time structured data collected at the point of care, which aligns quite well with many of the data elements that folks would care about in a case report form. So stage, performance status, and what's happening with the disease. Those are all data points that are usually tracked on a clinical trial. And in fact, we are engaged in doing that. So we have many patients at both Mayo and the University of Wisconsin, which is our partner in this study, where the patients had structured data captured using something like our mCODE smart phrase. The UW actually uses a slightly different process using a smart form, which we could talk about if someone wanted to. And we did that data capture as part of the routine care, but the patients were also on clinical trials and CRCs were coming along and extracting the data out of the chart in the usual fashion to a case report form. And so it gives us a really unique and interesting opportunity to look at how structured data captured as part of routine care compares to the gold standard of case report forms in terms of accuracy and completeness and timeliness. Again, that work is ongoing, but I'm going to tell you that the early signals that we're seeing suggest that, yeah, it actually works pretty well. And guess what? This data that is structured at the point of care is available much faster than the data from the case report forms because we're not waiting for someone to curate it. So this might be an option for conducting clinical trials with lower burden over time, which is also something that the Alliance is working on, something called iCare Data Direct. So many of you on the call may be familiar with the Alliance's iCare Data initiatives, where they were using a similar approach, mCODE data, looking at cancer disease status in a specific field pre-built in Epic, trying to track time to treatment failure. And that's what we're hopefully going to be able to do as part of iCare Data Direct, assuming the funding gods are willing. But just kind of turning back to the question of why does all of this matter? What is it that we're really trying to do if we sort of come out of the weeds of our implementation processes here at Mayo? And I will note that in about 2 weeks, the entire Department of Oncology here in Rochester is going to sort of undergo phase 2, and this will become a department-wide, and then we'll talk with the rest of the enterprise about what else we might want to do. And we have lots of other places where we're supporting this data capture, including things like looking at LLMs and AI. So I'm just going to emphasize the transformational nature of structured data in your care delivery tool. So the data paradigm that most of us grew up on in healthcare was you structured your data outside of the EHR. You did whatever you wanted in the EHR. You basically treated it like paper, except it was easier to read because someone was typing it. Because we structured our data outside in cancer registries or case report forms and study databases, we had a significant time delay. We've also had to live with the resource-intensive nature of that manual curation. And we've had problems with not broadly reflecting our population because, especially when it came to studies, we didn't really reflect the underlying patient population. Routine creation of structured data that aligns with things you want to know about the cancer patient journey. And again, mCODE, minimal common oncology data elements, is kind of like the fundamental data set of these are the things I probably need to know to present a cancer journey story, either for a patient or for a population. Routine creation and capture at the point of care transforms that data paradigm. It enables you to do really rapid and very inclusive data capture at the point of care. It's creating real-world data for real-world evidence in your EHR that you can then push to other places, right? And the carrot for a healthcare system or the individual provider is it's creating data that lives in your system that can be used to drive practice and research. You need to educate your providers to tell them that and to support them in figuring out how to use it for their practice and research. But that is a significant carrot for most of my colleagues. I can't end a talk about data in healthcare in 2025 without talking about LLMs or large language models, AI, NLP, whatever your approach du jour is. I don't think, at least right now in 2025, that AI is a substitute for structured data. Maybe it will be at some point, but I think those of us who have any experience with the AI that is currently functional, things like our ambient listening, it relies on what it heard or what was present in the chart. There's a limit to what it can scan, and depending on how good the algorithm is and how much drift you're sort of compensating for, how often you're tuning it, you're going to take your time, your chances every time you ask an LLM a question. Running a query takes time and it costs money. There's a limit to how many characters you can look at. You have to be very careful or conscious of what data an LLM is trained on, whether that data is out of date. Is it staying current with the state of information in oncology? Is it searching the web? Is it able to do that? Because if it can't, it's going to be outdated very quickly. Every time we have a major update at ASCO or San Antonio or GI ASCO, the standard of care has changed. And it might hallucinate or make up an answer some portion of the time, whether it's 10, 20, 100 times. Now, humans also make mistakes, and so there's sort of an open question of, who does the worst job? I do think AI has a role in that it can absolutely today be used to speed up and ease the task of creating structured data with the clinician in the loop to validate it, at least right now, where if I was someone who just really as a physician worked better by saying stage is stage 1 in my note, and I don't somehow structure it, the AI or a large language model could prompt me at the close of a visit to sort of funnel that to staging and turn it into structured data. And that is absolutely something that's being worked on right now. Additionally, once you do it that way, once you sort of create structured data and with the clinician in the loop say, yes, this is true, potentially that structured data does not have to be used, does not need AI to create it or find it anymore and sort of define it. And that lets you sort of structure the cancer story behind you and use the AI or LLM tools in front of you, or since the last visit to look at things. And that means you're not chewing up all your processing power, regenerating the story over and over. So if we think of using AI to drive the structuring of data, to clean up our ragged edge and take in the new data, I still think there has to be a goal to structure it and sort of put it out there as, okay, this is our true story for a patient, and then in the aggregate for the patient population. That's my view. It may not be shared by everybody else, but I do also think that we have to be sort of looking at our system and financial issues. I don't think that for the most part, we really incentivize data creation. We sort of treat it as adjacent in some ways. Within the context of a clinical trial, absolutely, we're conscious of that effort, but we don't have endless funding and supply of research dollars. And we aren't really training clinicians, providers, NPPAs, other folks who train the chart to think about themselves as a source of structured data. Survivors and patients, co-survivors could also be a source of structured data through ePROs or other pieces, but we maybe can't rely on them to set things like stage. I don't know that we're always asking vendors to provide a place to capture data. Or if we are, we're not always asking them in the right way or having them do it in something that is kind of in line with the right clinician's workflow. So when we think about lessons we learned from eye care, as opposed to things I've just shown you, eye care actually struggled because in order to capture cancer disease status, the person entering that information had to jump out of their note and go to the problem list and enter it there. And that was, again, that piece that I highlighted with stage, where when you interrupt the process of creating a note and require a step outside of it, a step outside of your usual clinical workflow, you tend to see folks struggle a little bit more. And then, as I've sort of highlighted going through this piece of, are we actually really supporting systems, clinicians, and survivors in using this data, right? If we're going to create it, and I use it here for me at Mayo or for my colleagues here at Mayo, that's great. But what about whether we have systems and incentives for aggregating that, for putting that together? And I'd like to highlight a paper by my colleague Pete Gabriel and his colleagues at Penn, where they put together sort of a commentary about re-envisioning the paradigm and paying for what matters, right? So we're used to the idea that we used to be able to compensate whether a physician or an NPPA did a 12-point review of systems. And how often have you opened a chart and still seen a 12-point review of systems referenced, even though that hasn't been something we compensated for before, right? Why don't we compensate systems and providers for what matters, which is the data that is part of a cancer story or cancer journey, and enables us to get good, significant amounts of real-world data and thus real-world evidence much faster, right? So we're not incentivizing that process. We're in fact sort of allowing each of the healthcare systems to think about it or do it or not do it as they want to. And I would argue that if we don't start to pay attention to that, it's actually going to end up costing us a lot more to transform later on, or to cost us more in terms of having to potentially use LLM or other AI tools to try and generate this information, possibly at significantly more resource consumption, or not as well as we could do if we were using both tools more powerfully. So again, I think the value of information is priceless. You can't deliver the right care to the right patient at the right time and location without the right information, right? And if you can measure it, you can hope to improve it. If it's kind of amorphous and you're relying on anecdote, then you're not going to do much better than that. So my concluding pitch to you is, if we want to do a better job, we got to have more data, better data, faster data. And we need this transformation to basically occur as rapidly as we can get it to move forward. I'm happy to take any questions. I did see a few things going off in the chat, but Brian didn't interrupt me. So I do want to point out, I am presenting this on behalf of a very large team of people. There are lots of folks who've been engaged in doing this work all along. I also do want to say that I don't speak for all of Mayo with this work. I have colleagues across the system who would argue with me about whether this is the right way to go. But Yeah, so, all right. Hopefully I kept everyone awake.
Very good. Thanks, Amy. That was very helpful and clear, and appreciate your preparation and thoughtfulness there. There are a few questions in the chat. Larry first asked whether the material that you were presenting earlier could be captured in the observations reference in FHIR, resource in FHIR. And I'm wondering if you want to get technical on the FHIR standard, if you want to talk about, which FHIR resources the records that you're capturing in a structured way get stored in.
And I'm not sure I completely understand Larry's question. I'll be honest. So much of my work is focused on the part of like, if it's not even there to transmit, does it matter what resource you use to transmit it or to aggregate it, right? Like first you have to overcome this step of structuring it somewhere in the EHR. And then a lot of these pieces about what standard or what language or where you locate it to. I actually, in many ways, am happy to defer to the EHR vendors in terms of what they're using or where we're putting it. I don't know if there's something more particular that Larry's thinking about when he says that. So he's saying he can do that with FHIR. I don't know if Larry wants to come off mute and sort of like expand on the question.
Hey, go ahead, Larry, if you like.
How's that?
You're still muted. Oh, there you go, Larry. Go ahead.
There you go. Yeah. Well, the fact is that if there's a data stream that we could capture, all of this could be literally that's what FHIR does is it rationalizes data, right? And FHIR, the observation API in a FHIR system is really where you aggregate information from everything from vital signs, measurements to anything, really.
Disease state. Yeah.
Once it's so, this is probably something we ought to take off, off this record. But this can be done. I just think it's a very doable.
Yeah, and I think from the standpoint of, can you transmit the data to other places? Yes, right? Like that's the ultimate step. Take it out of a system, a healthcare system's EHR to another place. Now, I will tell you, right? Each of our large academic institutions will fight you tooth and nail if you start to take our data without our permission. So like there's medical legal pieces around this that kind of come up. I don't know. I think we're sort of talking in the same line in the same way. What I'm saying is, if it isn't structured or digitalized or made discrete at some point in the cancer journey, we can't hope to transmit it anywhere else. And I don't necessarily care how we go about the transmission and the aggregation and the collation. In many ways, I'm sort of agnostic about what tool gets used on that layer. I just need more data on larger groups of patients so that we can do a better job of treating our patients with cancer, right?
Well, we should just talk someday when, we've got a little time and we can, and I think we could, we could get there. That's my point.
I think we can. It's not, I don't know that the technical problems are the major barrier. I think it's many of the other socio-technical pieces or medical legal pieces that kind of come into play here. All right.
Sure. Anoop wants to add something to this conversation, and then I'll take the next question out of the chat. Go ahead, Anoop.
Yeah, no, thanks. No, I just wanted to kind of add, I've been part of the CodeX group for prior auths, and I agree with the point that what we observed, we were looking at one of the radiation therapy EMRs, and we observed that a lot of information is not even available in structured form to map it to the FHIR resources. So we were exactly facing this challenge that everything sits in unstructured nodes. And once it's available in a structured format, we could then map it to, either
anything else
or conditions FHIR resources. So I agree that's been a challenge. So this has been very informative and how we could at least point the data into a structural format. So makes sense.
Yeah. Right. Yeah. And again, people argue all the time about like, oh, well, maybe some of this wasn't granular enough. we argue all the time at Mayo as we do this work about like how much data capture do we have to have. Our cutoff of 80% target here has been pretty arbitrary, but we're like, well, 80% represents most of the data. Unless we find that the 20% where we don't have the data is like following some sort of pattern, or it's not random, where we're missing consistently a group of people or a provider. You know, we can live with 80% of the data in this way. Brian, I've lost a little bit of track of like what else we might have out there.
Sure. So we have a question from Kelsey. She indicates, of the 5 data elements, disease status, ECOG, et cetera, in the mCODE smart phrase, which data elements need to be entered outside the note in order to be populated in the note versus data that was only populated in the note?
And this probably, I could have maybe done a slightly different screenshot, but I'm always a little bit leery of doing massive screenshots of both the Mayo EHR as well as just Epic in general. People tend to have feelings. So some of this requires you kind of know a little bit about how Epic staging functionality works. So we could have actually built a system where you structured all of it inside the note. That would have required us to rebuild things that were already in place in Epic. Namely, there is staging functionality available in Epic that is in line with the problem list. So those of you familiar with Epic and cancer would know that if you find a malignant diagnosis on the problem list, you can stage it there. So to stage a patient using Epic functionality, you jump out of the note into the problem list. Once you've done that, once you've staged a patient, and for most patients, staging is an event that happens once, twice, maybe 3 times, depending on whether you're a staging purist and believe that it's fixed for all time, or whether you can come back if there's a recurrence. And don't come after me, folks. But staging exists as a functionality offered by Epic, where they're doing all the upkeep, they're doing all the maintenance, they're taking it straight from AJCC, and we're like, we're not going to reduplicate that effort. That is a waste of our IT time and resources to keep up with that. We're going to direct our folks to stage there, partly because if you do that, it's visible across the whole Epic instance, right? Everyone can see it. Our ED colleagues can see it, our surgical colleagues. So we're able to maximally leverage it by placing it in the point and using the Epic systems. And then we don't also have to support it from an IT build standpoint. We do have to support from an IT build standpoint right now, disease status, ECOG performance status, intent of treatment, and intent to change treatment. But we also felt that was okay because those change from encounter to encounter, as opposed to being fixed the way stage is, or at least stage is more fixed. And less subject to change.
Thanks, Amy. So the last question in the chat right now is from Stacy. I'll extend Stacy's question. Stacy's question is, what do you need from others in the technical community, from EHR vendors, et cetera, to help make the case for broader implementation? I guess my question will extend on that is, what can the CodeX community do to help move things forward? Of course, we're proud of the work that went into mCODE. We're proud of extending that, and the work that you shared about clinical trial matching, registry reporting, prior auth, data direct. We're doing that sort of work. What other advice would you give the CodeX community of other problems that we can solve to help really improve clinical care and research and clinician experience? So that's Stacy's question plus mine. Over to you.
Plus yours. And I may also beg for some help from the audience, because I see, as you know, there's folks like Nancy Campbell on here. I see Larry on, right? And these are folks who've also given a lot of thought and time and energy to these questions. I think part of it is we need to stop the myth that this can't be done. It can be done. And not only can it be done, you can use providers, physicians, and PPAs to capture structured data at the point of care. You do have to be a little thoughtful of, let's use them to create the data that really only they can provide, and let's try and use other systems to provide the other pieces of information that might be able to come from other places. And I don't think this is an issue unique to Mayo, but the number of times I see someone touch the chart and put in information as free text when there was a different tool that made the data structured is mind-blowing, right? We just don't have the right mindset. So there's a piece of education, of conversion of our community to understanding this importance. There's a piece of arguing for incentives, and really maybe even thinking about guidelines to cancer centers. How much structured data do you have available? How much are you creating? I see Larry's got his hand up, so I'm sure he's going to say something brilliant and profound that I should have thought of, but
it's a high bar. Larry, over to you.
Yeah, right. I can't think of anything more profound than what you've said. It was a really terrific work, Amye, and it was a great presentation. I wanted to make a couple of comments and then ask you a question. I wanted to agree completely with your comments about LLMs and AI. They're sexy terms. Everybody's interested in them. There's lots of stuff. People want to write papers and get grants. And
it's the new thing, right?
Yeah.
It's the new sexiest
Yeah.
thing.
Smart forms aren't so sexy, and it's hard to get
Not
funding
anymore.
for them. But when we look at records, the whole issue of missing data, and AI, can't find missing data. And it's a huge problem. And the smart forms, which, as you know, Amye, we're also piloting at Penn.
Yeah, I know.
They drive people to ask the questions that we want answered. And so we not only get structured data, but we get more complete data. And I don't think you can emphasize that enough.
Right. Yeah. So Sumitra and I actually wrote a piece in the ASCO Daily Post, and I wonder if we should do something around that again, Larry, which is, and I think we saw this too with eye care data, right? Like this data missing, this problem is real. You can't tell why the data is missing. You can't tell if it's missing because it doesn't apply, or
Right.
is it missing because someone didn't put it in there. And I think one of the tools that we've leveraged for our staff here is our OPAs, our practice advisories, those supposedly intrusive alerts that physicians are supposed to hate, right? They actually ask for them. If you build them properly and you have enough structured data to make them apply only when they really should be firing, they support you in doing your job. They decrease your task load, right? It's the improperly tuned, too broadly applied practice alert that drives the alert fatigue. And so one of the interesting things for me is, I gave this presentation to the my GI colleagues yesterday, and not only did no one complain about the data that we've now been asking them to enter. Larry, are you ready for this? They wanted another smart list. They wanted me to add it line of therapy. And I'm like, are you guys sure you want to do more data entry? And they're like, yes, please. So I think to me, that's really interesting to those of us who hear constantly that you can't get physicians or NPPAs to do this. And I'm like, you can. That education piece, though, is really profound. And I don't see us talking about that enough. And so that's why I'm always excited to come talk at something like the CodeX community and see what we can do to sort of push that messaging out there, as well as think about other ways to use the information.
Yeah. So, and, going along with what you just said, I think if you use these smart forms correctly, and don't feel obligated to repeat what's in the smart form in eloquent prose, it actually saves you time rather than costs you time. And it takes a little bit of convincing to get our clinicians to understand that.
Yeah.
The other thing
different, and they, I don't like different.
Right. Change is hard. Change is always to be resisted, right? So the other question, you talked mostly about data input, but, mCODE to some extent is, standardizing the output and the transfer of it. And do you want to make any comments about what it took at Mayo to get this to come out as mCODE data? Because you can do all these things and then it's still in Epic, whatever Epic data looks like, and it's not mCODE data.
Yeah. So, I mean, I think for me, and I'm just going to screen share again. Hopefully I can do that and like talk and drive backwards. So one of probably the most important things I did. So, we were doing this work at the UW, and when I came to Mayo, we were like determined to, in talking with my colleagues here, we were sort of really set on trying to do this, and hopefully we did it smarter. So one of the keys for us was the data sets that let folks look at these aggregate reports And if any of you are interested, there's a woman named Linda Bosserman who does a lot of this work out of City of Hope. She also has done a lot of data structuring, and they have phenomenal dashboards. But like just showing the group this sort of information and having them have the aha moment of it's fine to see it, you know, in your note, but that's kind of an N of one. And if you think it helps you make your note, as Larry just alluded to, you know, you might kind of suck them along this way. But for the resistors, and there always will be one. So I didn't point this person out when I was talking about the impact of phase 2. You see this guy sitting right there. I know exactly who it is. I'm just waiting for this person to retire. Not short of coming to clinic and entering the data myself. I'm not going to budge that individual, but that's okay because everybody else washes that person out. But this kind of being able to extract the data out and organize it and allow people to sort of play with it helps. I could use about, you know, 50 more analysts and I could have us further along, but it's a precious resource. So I don't know if I answered your question, Larry, as I was kind of talking about that. I think you're pretty familiar with these challenges as well.
Yeah, but it's a technical issue, right?
Technical issue at that point, yes.
Yeah.
Yeah.
Okay, well, thank you so much to everyone for your engagement and questions. Thank you to Amy for your clear and helpful presentation. Thank you for answering all of these questions as well. We really appreciate you taking the time and coming to share and encourage the CodeX community that the work that we're doing here actually matters and has an impact and is really being used in clinical environments. And so that's just really exciting. That's really positive, and we thank you for all of those things. I just want to remind folks that our next community of practice is on Friday, the 27th of June. And so mark that in your calendar, place a hold there for yourself, and invitations and details will come out in due course. Once again, thank you to my CodeX colleagues for supporting this and for inviting Amy to participate. And I will now say thank you and good afternoon and enjoy your weekend.
Thank you.